Everyone, please take your seat. The program is about to begin. Please welcome Senior Director, Policy and Government Relations, Stephanie Arnold-Pang.
What a week it has been. What a week it has been. We have danced, we have eaten, we have engaged. What we know from this work and the history we share is that there is space for joy in the middle of very hard things. I was proud to organize this session, Coming Back Stronger, Leaving No One Behind. One of the reasons I was proud is that this content reaches into the core of who I am and why I do the work I do. Since we last gathered in 2019, the environments where we work, live, and play have drastically changed. Rights of individuals are being questioned, limited, and denied. Access to health care is being restricted and denied. And now, in 2023, we find ourselves in a place, depending on where we live, of no longer having access to things we may have once taken for granted. So please stand if you feel less safe where you live due to your race, gender, gender identity, or gender expression. Thank you. Please sit. Please stand if you live in a jurisdiction where gender-affirming care is being limited or denied. Thank you. Please sit. Please stand if you live in a jurisdiction where drag performances have been banned. Thank you. Please sit. And please stand if you live in a jurisdiction where books or school curriculum pertaining to people of color or LGBTQ individuals have been banned. Thank you. Please sit. Please stand if you live in a jurisdiction where in-school discussions of sexual orientation or gender identity have been limited or denied. Thank you. Please sit. And please stand if you live in a jurisdiction where access to abortion is being limited or denied. Thank you. Please sit. Depending where we are providing public health and sexual health services in environments that are drastically different from one another. But we are here together. So please stand if you have stood during any of the times in my opening comments just now. We all have concerns about the limitations and these restrictions. We are here to help one another, to provide care, support, and services for those who need us. To continue this conversation, in this plenary, we will hear from speakers who will provide an overview of the loss of rights experienced by so many and the important role of public health. You will hear from an STD director on how he held the line when rights of young people were being threatened in his jurisdiction. And you will hear key lessons learned from providing reproductive health care on how we can continue to move forward when it feels like everyone is against us. Thank you for your work. Thank you, each and every one of you, for doing what you do every day to ensure that no one is left behind.
Please welcome MFAR Vice President and Director of Public Policy, Greg Millett.
Hi, good afternoon. It really is a pleasure to be here today with every one of you. The conference over the last couple of days have been incredible, just watching the plenaries as well as some of the sessions that I've had the privilege to go to. And what Stephanie was just speaking about earlier, I think is a really nice way to have an intro to what I want to discuss today, which is a bit difficult, but unfortunately reflects the world that we live in currently. So I want to talk a little bit about the factors that complicate our efforts to address STIs and other infectious diseases. And I want to begin with something that we hear a lot. Dr. Fauci, we all love him. He always would say, you know, we have the tools to end the HIV/AIDS epidemic. And I agree with him. We do have the tools to end the HIV/AIDS epidemic, but we're not necessarily using those tools. And it's not just HIV. It was the same thing with COVID-19. I'm not sure if many of you guys were following Eric Topol on Twitter, really well-known infectious disease doc. He had all this great information on COVID-19. He also was distressed over the fact that despite the fact that we were the first country to have COVID-19 vaccines, we fell far behind in terms of full vaccination. At one point, just 2 months after having vaccines, we had already fallen to 45th among other countries in terms of full vaccination. So it goes to show that having the tools is not sufficient. More must be done. The other issue as well is that it's not just having the tools, there are other impediments that are in place that make it harder for the work that we all do on any given day. And this is a report from the National Academy of Sciences, came out in 2019, where they basically said that healthcare only accounts for 10 to 20% of the determinants of health, a lot of the work that we do every day. Most of the determinants of health, as much as 50%, come from the physical environment. So there's an awful lot that goes into people's health and how well they're doing based upon their physical environment. And what does that physical environment look for many of us these days? Here's an example.
Then we know who you are. We know who you are.
Keep it calm.
No more masks.
Keep it calm. Keep it calm.
No more masks.
We're on these guys' side. They're on our side.
No, they're not. They're not on our side.
The police are on our side. The police are on our side. Let's calm down.
Yes.
Calm down.
We
know who you are.
We know who you are.
You can leave
We know
freely,
who you are.
but we will find you, and we know
You will
who you
never
are.
be allowed in
We know
public
who you
again.
are.
What you just saw was a school board meeting in Williamson, Tennessee. The person who was in the car was a public health official who was testifying in front of the school board about some of the preventative methods that are required for COVID-19. Now, there are two reasons that I showed this. One is because Williamson, Tennessee is where my husband is from. He went to schools in that county. The second reason I wanted to show it to you is because it made national news because people were so amazed that public health officials were being attacked so brazenly over collecting and giving accurate data around COVID-19. A lot of this is sort of the backlash that I think many of us have been experiencing in small and larger ways over the past 3 years. And I don't know about you, but when I got into public health, that was not something that I signed up for. By a show of hands, how many of you have had some difficult situations over the past 3 years? Quite a few of you. So the environment has changed. It is more difficult for us to do some of the work that we're doing. There is a backlash against science as well as public health. But there's something else that's taking place as well. And I'm calling this an epidemic of ignorance on this slide. But there is a backlash against many other social issues that make it difficult for the people that we serve to be in a physical environment that optimizes their health. First, of course, is we're seeing rollback of rights in terms of abortion, where there are many states, you can see in very red here, that are restricting abortion access. We're also seeing gender-affirming care for transgender people under attack, with the Human Rights Campaign saying that as much as 31% of transgender youth already live in states where gender-affirming care is no longer available. And an additional 14% live in states where gender-affirming care is in the process of not being available. So that's nearly 45% of transgender youth. We're also seeing in state legislatures as of last year that over half of state legislatures introduced LGBTQ, anti-LGBTQ bills over the past year. And unfortunately, we're also seeing a lot of bans on books. The American Library Association found that in 2022 alone, that there was a 100% increase in book banning. And it was so bad that it was the worst that they've seen over the years that they've actually been collecting this information. So we're in a qualitatively different environment in terms of public health. We're in a qualitatively different environment in terms of the physical environment that can either make the lives of our patients healthier or less healthier. And unfortunately, when you take a look at the book bannings, I'm just going to go through some of the things that we're seeing right now in our nation. The books that were most likely to be banned, probably not a surprise to anybody, but over 50% were LGBT books. And we know that a lot of this, the genesis of it came from Florida with the Don't Say Gay bill that had passed there. Unfortunately, in Louisiana, just last week, the Louisiana House just passed that as well. It's now going to the Louisiana Senate, and we might see that same type of legislation here as well. And unfortunately, when you take a look at the result of this type of legislation, it's almost absurd. I mean, we just saw on national news yesterday that there's a teacher in Florida who actually might lose her job and also might be prosecuted because she showed a Disney film to her kids to try and calm them down. A Disney film that happened to have a mixed-race LGBT character. I mean, is this a dystopian universe or what? And this has real health effects. I mean, there's already a lot of literature showing that among LGBT youth, when you live in environments that are not supportive, that they're more likely to have depression, more likely to commit suicide, and particularly transgender youth. But there's also sexual health effects as well. This is a study that a colleague of mine, CDC, published a couple of years ago, which is a meta-analysis looking at homophobia and its relationship with sexual health for gay and bisexual men. And what he found was that homophobia, or experienced homophobia, was associated with a 33% increase in sexual risk for gay and bisexual men, a 34% increase in HIV diagnoses, as well as an increase in less likely being able to be in the continuum of care and staying in the continuum of care if you experience homophobia and you're HIV positive. So these things have real health consequences that is going to affect how we do our work and the health of the people that we serve. Now, one of the things that we saw quite a bit during the COVID-19 pandemic is that structural racism was associated with poor outcomes for people of color. And structural racism had a context that we saw for SARS-CoV-2, which was similar than what we've seen for STIs as well as HIV. This figure is from a paper that I published in the middle of 2020, where I was looking at the different ways, these different pathways, where we've seen these determinants of health make it easier for people to get STIs or HIV, but also exactly the same pathways for SARS-CoV-2. Now, a lot of that is based upon a history of structural racism. And unfortunately, we are living in a society now where we actually want to take our history. We don't want to discuss those uncomfortable things that are responsible for why we see inequities in terms of health and other inequities in our society today. And I think, quite honestly, that is something that's problematic. If you do not understand the source of a problem, you're not going to be able to address it. It's really quite that simple. And unfortunately, ignoring that problem is not going to take away what we see every day in terms of STIs, where you see that African Americans and other people of color are more likely to be diagnosed with gonorrhea as well as chlamydia. It also doesn't change in terms of what we see with HIV incidence in the United States, where from the mid-1980s on, that the epidemic has been primarily among African Americans. And then in the last few years, we've seen an increase in incidence among Latino Americans who have now eclipsed whites. Also, ignoring that history is not going to change a history of many different pathogens most likely to affect communities of color. This is from a paper that was published several years ago where they were looking at cytomegalovirus, herpes simplex virus, human papillomavirus, and Toxoplasma gondii. And they were looking at diagnoses in the United States between 1999 and 2013. And the only thing that you need to look at in this is the black part of the graph, which is non-Hispanic whites. It didn't matter what year it was, you saw fewer infections in that population as compared to communities of color. A lot of that is because of these structural issues that we're seeing that place many of these individuals at greater risk. And unfortunately, systemic racism is also associated with greater lives lost. Unfortunately, during the COVID-19 pandemic, very early on in the pandemic, some colleagues and I came together to publish a paper to see the degree to which African Americans were more impacted or not by COVID-19. And what we found is that those counties that are disproportionately African American, by April of 2020, remember shutdown was only March of 2020, by April of 2020, disproportionately black counties accounted for 52% of the nation's COVID-19 cases and nearly 60% of the nation's COVID-19 deaths, that early on in the pandemic. And there was just another study that was released early this week that found that African Americans have lost a total of 2 million excess deaths over the past 22 years that was accelerated under COVID-19. And during the COVID-19 pandemic, there was another paper that was published. It was a brilliant analysis in Proceedings of National Academy of Sciences, where they found that white COVID-19 deaths would need to increase by nearly 6-fold to actually equal what we see in terms of deaths for African Americans on any given year before COVID-19. So structural racism has some real consequences, and we're not dealing with it because we don't want to talk about the past. We don't want to talk about the history, and we're not able to actually address those issues. And it's not just African Americans where we're seeing this disproportionate impact. We're seeing the same thing that's taking place among all of us. I mean, we've seen that the United States now has lost a cumulative 2 to 3 years of lives lost for all of us. But it's been worse for African Americans who, over some time, we were actually gaining and doing well, as you can see by this graph. But when the time COVID-19 came in, we lost over a decade and a half's worth of gains in terms of making sure that we have some parity with whites in terms of longevity. I think the biggest issue, though, that we see in this graph is what's taking place among Latino Americans who are also disproportionately hit by COVID-19. Now, there's something called the Latino paradox in the scientific literature. Like, Latinos are more likely to live longer lives as compared to whites. But what we've seen with COVID-19 is that Latino communities were so disproportionately impacted that that edge is now completely erased, that they are no longer living longer lives as compared to whites. So physical environment, not addressing structural racism, has real health consequences that we all have to deal with. And then we see the same thing in terms of vulnerability for immigrants. Now, many of you have already seen the news in terms of the last week on Title 42. It's going to expire, and we're going to see this increase in immigrants, and we're going to be overrun, and it's going to kill us in our health systems, et cetera. That actually didn't come to pass. And the way that I like to liken this is, I don't know how many of you guys get on Instagram. I probably shouldn't in my mid-50s getting on Instagram and taking a look at stuff. But I really love those memes that they have about Instagram versus reality. And they show Instagram, you have this quiet beach and it's beautiful and you're there with your partner and it looks so amazing. And then they show the reality, which is a beach that's actually really filthy and filled with people and everything else, to show just how Instagram is just not with it. It kind of feels like that with this rhetoric that we hear all the time about immigrants, where it's just not based upon reality. But this is what the reality of what we see immigrant populations actually dealing with. There was a paper that was published, it was in CDC MMWR, looking at health workers in meatpacking districts. And they found that among those healthcare workers during the COVID-19 pandemic, that the overwhelming number of cases disproportionately affected Latino healthcare workers, quite a few of them who were people who are undocumented. And we also saw during COVID-19 that those individuals who are monolingual speakers of any other language other than English were far more likely to get COVID-19 and to die from COVID-19. This is a paper that was published in JAMA, which found that if you're a monolingual Spanish speaker, if you're a monolingual speaker of Tagalog or many other languages, that you are far more likely to not only get COVID-19, but to die from it. And a lot of that is because health messaging is not permeating those communities that might need it the most, who don't speak English, as well as the fact that those communities are also marginalized in the places where they live, in physical environments that place them at greater risk. And now we're in the middle of talking about the debt ceiling and where we're going to cut in terms of the US budget. And unfortunately, a lot of the places that people are talking about where they actually want to cut are specifically those programs for people who are poorer. That's a mistake. That's going to make all of our lives and all of our jobs harder. And one part of the reason why I say that is because there's a long history in public health showing that if you are lower income, there is a greater morbidity of disease. And we also saw this for COVID-19. These were data very early on in New York City from the New York City Department of Health, where they found that those individuals who had the lowest incomes represented the greatest number of cases, the greatest number of hospitalizations, and the greatest number of deaths. So cutting programs that support low-income people is just not good. Then there's also the issue of what's going on in terms of abortion in the United States. And we saw that in Tennessee earlier this year, that the health department actually cut funding for HIV prevention programs, mainly because those programs served transgender individuals, but also Planned Parenthood in Tennessee. Now, count me as crazy, but I think this is a little bit short-sighted. And why I say that is because Planned Parenthood just doesn't do abortion services. Planned Parenthood provides PrEP access. Planned Parenthood does Planned Parenthood does STI screening as well as STI management and treatment. So cutting those services kind of feels to me like you are, taking off your nose to spite your face. And when you think about the fact that this is getting cut in the middle of an epidemic among women for primary and secondary syphilis, where we're seeing a sharp increase, just doesn't make any sense to me. Somebody tell me, does it make sense? So we need to move away from these politics that don't make sense. And it begs the question, who's coming up with these policies? And when you take a look at the demographics of the people in Congress, this is data from 1930 through 2020, you could see that there's not as many people of color in Congress. We see people starting to seep in a bit in the 1960s, but still not a lot of people of color. Right now in Congress and the Senate, of our 100 senators, 88 are white. And then it's not just Congress, but we're seeing this at the local level as well. The United States is 40% people of color. But in Congress, only about 17% people of color, and in state legislatures, even doing more poorly, only 14% people of color. Now, if you are responsible for making policies, but you don't know or have walked in the shoes of many other people who do not look like you, how effective do you think many of those policies are going to be? And it's not just that. We're also dealing with many other issues that's affecting our environment. We've been talking about syndemics from the very beginning of the plenaries that we've had earlier this week. And when you take a look at syndemics and infectious disease, it's really compelling. I mean, in 2015, we had the hepatitis C outbreak among people who inject drugs in Scott County, Indiana, as well as HIV, as well as STI. 2016, all the media was focused on Zika. Zika's coming for you, you know? 2018, we had a measles outbreak in many different parts of the US, and particularly where I'm from, in New York City. 2020, of course, we had COVID-19. 2021, we had COVID-19. And then it just became a whack-a-mole of infectious diseases by 2022, where we had polio, meningitis, as well as monkeypox. And just to put a finer point on it, there was actually a time in last October, where New York City was under public health emergency for polio, COVID-19, as well as Mpox. What do you think that does for public health workers who are trying their best to address all that needs to get done with very little or to no funding? And all of this is something that we actually see. These were data that were published years ago by Kaiser Health Foundation as well as AP, showing that most states spend less than $100 per person on public health. And then we've been seeing this precipitous decline in public health workforces in terms of state as well as at the local level. This is a problem. And it's something that we have to deal with. And honestly, this was a study that came out in March of this year that just stopped me in my tracks. And why it did is because they found that between 2017 and 2021, that half of state and local public health workers left their jobs. Half in our nation. And then they went further in their analysis and they looked at those individuals who were under the age of 35 or those individuals who were new to their jobs within the first 5 years of their jobs. And they found that 75% of those groups left their jobs between 2017 and 2021. So we're not only between a hard rock and a hard place in terms of some of the policy issues, in terms of these many different infectious diseases that are cropping up, but then there are people who are leaving and not even staying. We're not even replenishing the young people who we're bringing in. So I showed my husband this presentation, and he looked at me, he was like, come on. He's like, are you really just going to say all that and leave people without any hope? And I told him, but love, you know that I'm kind of a glass, half empty person. And he was like, no, this is going to change. So thankfully, this part of the presentation is because of my husband and the reason why I changed everything. So here's some of the hope that we see. We're seeing that just in the last couple of weeks that in Republican districts and states that women in Nebraska as well as South Carolina in the legislature push back on total bans against abortion, which is incredible. And we're seeing that despite the rollback of Roe v. Wade, that support and polling for abortion is only increasing in the US. We also see that Medicaid expansion is actually coming to states that we never thought we were going to see Medicaid for. Just in the last few weeks, North Carolina adopted Medicaid expansion. And why this is important is because we know those states that expand Medicaid are more likely to have a greater number of individuals who are on PrEP, a greater number of individuals if they're HIV positive to be virally suppressed, and also to have lower diagnoses. In fact, that's what happened here in Louisiana several years ago, that a year and a half after Louisiana expanded Medicaid, they saw the biggest decrease in HIV diagnoses in well over a decade. So this is good news that we're seeing more states with Medicaid expansion. The other thing that we're seeing as well, too, is that support for LGBT communities has really increased exponentially. When I was a kid growing up in Brooklyn in the 70s and the 80s, even in New York City, it was hard to be out. I was scared to come out because I just didn't think that support was there. We're in a wildly different universe right now where over 70% of Americans support gays and lesbians, and support gays and lesbians in terms of our relationships, in terms of being able to adopt, in terms of being able to allow children, or the fact that we're not going back and forth on, are they born gay? Are they not born gay? It's like, just leave people alone. So it's nice to see that. And what makes this important is that it's much harder to demonize a group when you know them, when they are part of your family, when they're part of your friends, that some of these laws that we're seeing is just not going to sit right with a lot of people because they know that what people are saying about us is just not true. And the other thing that I think is really important as well is the generational shift that we're seeing that's incredible, especially Gen Z. Is there any Gen Zers up in the house around here? All right. Nice. Well, I just got to tell you, y'all are kicking it, okay? It is amazing the things that you're doing. So Gen Z, 1 in 6 Gen Z adults, or about 20% of Gen Zers, actually identify as LGBT. And then when you take a look at Gen Zers who say that they know somebody who prefers to use pronouns that are gender neutral, about 35% of Gen Zers. That's incredible. They know people who are trans. They know people who are queer. And then when you take a look at the diversity of Gen Zers, I mean, it's just mind-blowing. Nearly 50% of Gen Zers are people of color, with a quarter being Latino, which makes me happy because my family's from Panama and Cuba, so I'm really psyched to see that. So we're seeing a generational shift that's also going to come with different attitudes and hopefully a different Congress as well as different state-level legislatures, so we could actually see policies that actually reflect where we are in the United States and who we are. We're also seeing resilience in the midst of the epidemic. Despite COVID-19 impacting many communities of color, we're seeing a 1,000% surge in public health applications across the United States. People being affected by COVID-19 has made more people want to come into public health. Just the reason why I came into public health 30 years ago when I was watching friends dying in New York City from HIV. This is good news, that we have more people that we're adding to the ranks. And more importantly, we're seeing many more people of color who are applying to medical schools. And we're seeing black and brown businesses that were devastating during COVID-19 actually coming back. This is all great news and something that I think we all should be proud of. And honestly, I see the resilience that we're talking about in this slide with everyone here in this room. The first day during the conference when they were asked to raise your hand if this is the first time that you've been to an NCSD meeting, and well over half people raise their hands, is great. It's wonderful news. Welcome to the fold, welcome to the fight. And the fact that this conference has actually increased by up to 1,200 this year, after 3 years of not having the conference, is also wonderful and shows just how resilient we are. Indeed, all of us are coming back stronger. And we're going to be able to turn around all of these effects and policies that we're seeing that's not only affecting our health and our work, but the health of many of the people that we care for. Thank you for your time.
Please welcome STI Program Manager, Iowa Department of Health and Human Services, George Walton.
Good afternoon, everyone. So my name is George Walton. I'm the STI Program Manager at the Iowa Department of Health and Human Services. I've had the honor of serving in that role for about 11 years. Before I get started, I want to extend my gratitude to the staff of NCSD, members of the planning committee that put together this amazing conference, and everyone else who helped make this possible. Thank you for the invitation to speak today. Today, I have the opportunity to offer you all a few comments related to how policy developments at the national level can and do influence and affect all of us at state and local levels. I'm going to walk you through an example. It's kind of a case study of sorts for the epi-nerds in the crowd that like to think of it that way, of something that we recently experienced in my home state of Iowa. All right, so it started on a Wednesday morning, and this Wednesday really wasn't much different than any other, the exception being that we were in the middle of our state's legislative session, but otherwise pretty standard. And just like any other morning, I logged into my computer that day. I started planning out my goals for the day. We all start off that way, thinking that we can actually figure out what we're going to do. But as you all know, it's pretty common. You plan things out, something happens, gets upended, something unexpected comes your way. That's the nature of our work, right? We're used to that. But I have to say, I wasn't quite prepared for what was going to come across my desk that day. It was from one of our administrators who conveyed that there was an inquiry from one of our legislators. And that's not particularly unusual. Those of us who work in governmental public health, this happens pretty frequently. We often get inquiries to our department. Now, these could be anything. They may be looking for some stats, some procedural clarifications, explanations. And of course, we all know they may express some concern with some new programmatic activity, something that they didn't quite like, something that rubbed a constituent the wrong way. We're also used to dealing with those and responding to those kinds of inquiries. But this time, the inquiry was related to a law and a policy that had been long-standing and on the books for many, many decades. A legislator had contacted our department because one of their constituents was deeply concerned and upset by a letter that they had received from a local health system in their rural community. The letter was informing this individual that now that they had turned 13 years old, their medical record could be made private from their parents. Well, as it turns out, the letter was sent by the health system to this individual by mistake. This was not a 13-year-old. The individual was an older adult who had no children in their household. Nonetheless, this individual was still deeply troubled by the fact that an Iowa law would permit an adolescent to keep anything confidential from their parents. There was concern that this would violate parental rights. If this individual did have adolescent children, they certainly would not want their teenager to be allowed to keep any medical information from them. To take that a step further, why should any adolescent in the state be able to do such a thing? So the individual contacted their legislator and asked that whatever rules made this possible be changed, preferably quickly, so that parental rights in the state could be made whole once again. So, the story continues. Legislator made the inquiry of our department. Eventually, took a bit, but our administrators connected it to Iowa Code 139A-35, which in part states that a minor shall have the legal capacity to act and give consent to provision of medical care or services for prevention, diagnosis, or treatment of a sexually transmitted disease or infection. So, in short, it's the part of our code that makes it possible for adolescents to access STI services without first having to seek parental consent. This legislator wanted to know why a law such as this existed, with the implied goal of removing it, scaling it back, modifying it in such a way that consent could be limited to adults. I don't think I have to, as much as I would like to, get into all the barriers that this could impose. Everyone in the audience knows the power of laws such as these. We already know that it's difficult enough to make STI services accessible to adolescents, even with these protections in place in our states. There are dozens and dozens of barriers that any one of us could list off related to access to services, particularly for youth and adolescents. So, the notion of scaling back minor consent and adding such a monumental barrier is a nightmare, to say the least. And of course, not to mention the fact that every state in the U.S. has some law in some way, shape, or form that protects a minor's right to confidential services, STI services. So, scaling this back in our state would have made us unique in a way I hope that we never are. So, getting back to the story. When this inquiry came in, the administrators in my department tasked me with drafting some explanations, providing evidence for this, trying to justify why such a law shouldn't be scaled back or removed entirely. I panicked, I'll admit it, I lost my cool a little bit. It wasn't the first inquiry that we'd ever received from a legislator. I'd fielded things like this, similar to this before, and it wasn't even close to the first inquiry we got that session. And we all know who do work like this at all, that there's always some challenges in framing, navigating comments in ways that make the most sense and land best with legislators. This one seemed different, though. Honestly, I was naive. I hadn't thought through having to justify something like this. Since I came into this field, to this sector, it's something that I'd always viewed as a fundamental right in STI prevention. The right of adolescents to consent for testing and other STI services. It's been a cornerstone. So I thought it's okay. Work with my team and our partners, draft something well thought out, get some cohesive messaging. I'll take my time and get it right, because I have plenty of time, right? Right? No. Reality hit me again. I discovered that all of this needed to be drafted and submitted by close of business the following day. So I did have one day. I was grateful for that. But still, not a lot of time to pull all this together. At least not in a planned and well thought out way that I would have liked to for something like this. But we had to deliver results. We couldn't let this inquiry go unanswered, because inaction surely would have resulted in deleterious policy changes to be introduced. So I don't know what you all would do, but I'll tell you what the first thing is that I did. I leaned into our partnerships. And the strongest one that we have is our partners in family planning. I picked up the phone, called my dear friend, Colleen, at the Family Planning Council of Iowa at FIPSI. And in our state, the STI program in FIPSI, we've had a long-standing partnership. Predated me. I've been here 11 years, but all the way back, Tim Fertility Prevention Project, IPP. Can I get a round of applause for IPP, please? Thank you. And even its predecessor programs. So we've been working together a long time. I knew I could count on her. She and I made a plan. We each took some different elements of the inquiry that we could respond to and provide some evidence for. The task seemed huge, especially given that short timeline that we had and the dramatic implications of failure. But after we took a moment, commiserated, we picked ourselves up and we got to work. And you know what else? I leaned into the rest of the members of my STI program. So at the beginning, I had a lot of things planned for that day. That day, we also had one of our regular DIS and STI program meetings scheduled. So I kept it, met with our team. I shared the concerns that had been raised and what was going on. And as DIS do, they quickly spouted off half a dozen points to consider, arguments to make, and evidence to offer. We all know DIS are used to thinking on their feet, and our team once again proved their skill and calmness in the face of some frustrating circumstances. I'd like to just pause for a minute and get another round of applause for DIS. I'll say once again, going to other duties as assigned, so thank you for that. And I also reached out to the policy team at NCSD. With everything going on, I didn't feel like I had the time to make the call and talk through it, so I just quickly, hastily sent off a message to some NCSD policy staff. I explained the situation and asked for any help they could offer. But honestly, with the short turnaround time, I did not expect them to drop everything and come up with something. But you know what? They did. Fewer than 24 hours later, the NCSD policy team got back to me with some well-researched and a cohesive policy document with a litany of examples and evidence for me to choose from. It looked like they'd spent weeks putting this together. No, they just did it that quickly. I want to thank the NCSD policy team again for their dedicated and responsiveness. Sorry, you got to give another round of applause for the policy team. They were amazing. All right, so these partnerships came together. I compiled those resources, the evidence, the explanations that we gathered as a result of the work with our partners and me. I sent it on to my supervisor, who put the beautiful finishing touches on it, and then shared it with our upper administration. Then I waited. And ironically, as anxiety-filled as it all began, it really just kind of fizzled out without much attention. But really, this was the best possible outcome given these circumstances. Legislation was not introduced. We made our case, and the strong benefits of having such a law were conveyed. In this one specific instance, the crisis was averted. Amazingly, logic and sense prevailed this time. But this is not the end. We all know something similar can and probably will happen again. And we know not every day is a win. As we all know all too well, there have been some devastating setbacks. Long-standing rights are called into question. Precedent is not enough. So, as I wrap up my comments and my time expires, I'd just like to leave you all with some 3 closing thoughts that came to me as I was thinking through this. Number 1, get prepared. Preparedness drills are common in public health, right? Maybe we think about them more often in other contexts, like preparing for natural disasters, but nonetheless, emergency preparedness is a key component of public health. It's time for the STI sector to conduct emergency policy preparedness drills. Because what will you do when something similar happens in your state or locality? How will you respond? Especially when there's little time to gather yourselves. So build your cases and strategies now. We can't wait for our policies to be threatened and simply react. Be proactive, build support now. And if you're already doing this, please share your best practices with others in our sector and NCSD. Number 2, celebrate your wins. Whether they're big or small, celebrate in whatever way you can with whoever you can. Those who are close to you and who value this work as much as you do. And I'll say this is absolutely one that I could do better with. We're also focused on putting out that next fire that we don't take enough time to celebrate and re-energize. And number 3, Lastly, know and grow your partnerships. You all heard that's the first thing that I did. You cannot effectively do this work alone. There are things that we can do in our agencies and in our positions. That's very true. But remember, your partners in related agencies and sectors may be better positioned for certain aspects and actions. You can complement one another. You can play to each other's strengths. Do that. Think about who you're going to call when something like this happens in your jurisdiction. Who will you lean on? And partnerships, circle back to the first two that I mentioned. Your partners are who you will prep with and who you will celebrate with. I want to thank you all for allowing me the space and time to share this example and work with each other, grow with each other. We need each other to do this work. Thank you.
Please welcome President and Chief Executive Officer, National Family Planning and Reproductive Health Association, Claire Coleman.
Hello, thank you for having me here today to speak. I'm really pleased to join Greg and George, and it's always lovely to have the opportunity to have last word. NIFR is an association that represents nearly 1,000 publicly funded providers of contraception and sexual health care across the country. It's a diverse network of state, local, city health departments, federally qualified health centers, Planned Parenthood affiliates, feminist health centers, other private not-for-profit agencies. Many of you work alongside NIFR members in the health department or in partnership in the community, and you see us in action. Our network exists to meet the contraception and sexual health care needs of people, particularly with low incomes or who are otherwise vulnerable. I'm sorry that I couldn't be here for all the content. I found myself especially drawn to the sessions on burnout and self-care and trauma fatigue, and I think you'll understand better when I tell you why I'm here. I'm here today as a partner and an ally to tell you about the path that those of us who work in contraception and abortion care are on. We are ahead of you, but we are all implicated. The last time I was invited to speak with you, Title X, the National Family Planning Program, was headed towards the most disruptive and profound changes in its 50-year history. A dangerous program regulation had been put into place that restricted the services and slanted the information available to patients seen in a Title X setting. That program regulation shattered our network and eviscerated care for millions in need. The Title X network went from seeing nearly 5 million people at the end of the Obama administration to seeing 1.7 million people in 2021. In other words, the Title X network is only in the very early stages of recovering from the Trump crisis. And this setback is one of a number that the Family Planning Network has been grappling with. The willful conflation of abortion and contraception and a relentlessly ideological drive to ban abortion has had some significant impact on contraceptive access. 17 states, for example, have some restriction on public funds for contraceptive services going to those who also provide abortion care. And as an illustration of the impact that a restriction like that can have, Guttmacher research from last fall showed that in Iowa, barring providers of abortion care from the Family Planning Network led to a 2/3 increase in those who stopped using birth control. And then, last summer, the Supreme Court did what many of us said it would do: throw aside 50 years of legal precedent and overturn Roe v. Wade, putting the health and lives of millions of people at immediate risk. And as we continue to experience that harm and struggle to come to terms with the price that people are paying under the Dobbs decision, we also need to anticipate what's ahead. Because Dobbs puts a host of essential rights, including the right to contraception, at significant risk. And Dobbs is already impacting contraceptive access. In the Title X context, we are beginning to see this. States are not backing down when there's a Title X requirement they don't agree with and conflicts with their state law. Immediately after Dobbs was released, concern began to grow about Title X grantees not complying with the program's requirements for non-directive options counseling and referral. To be clear, those requirements are intended to be respectful of and responsive to the patient's wishes. If a person with a positive pregnancy test reacts with sheer delight at that news, their provider will follow that patient's lead. Counseling and referral for abortion, adoption, and prenatal care happen at the patient's request, led by their needs and values. That's the national clinical standard of care. Earlier this year, all Title X grantees were directed to demonstrate to HHS that their Title X projects were in compliance with the non-directive options counseling and referral requirements. Greg just talked about Tennessee refusing federal HIV prevention funds. So it will not come as a surprise to this audience that the state of Tennessee is the first Title X program in the country to lose its funding, more than $7 million annually, because the state refused to comply with the regulation on abortion counseling and referral, citing its state abortion ban. Tennessee enacted a trigger ban in 2019, and abortion became illegal from the moment of conception last July, 30 days after the Dobbs decision came down. And I wish I could say that one state's defiance of federal law will be the end of this, but I do not have that confidence. The successful effort to overturn Roe v. Wade provides a devastatingly clear template for how opponents will target contraception, and it's all on the table. It is possible soon, even if a provider is not offering abortion care, a state or private actor may assert that other services that provider offers conflicts with the state's abortion restrictions or prohibitions. It is possible soon that states could consider certain contraceptives to be abortifacients and therefore banned under the Dobbs decision and their state law. If science does not matter in the legislature or the courts, a state could try to claim that all contraceptives are abortifacients. Another way to get at that same result would be through fetal personhood laws or other state definitions of life beginning at fertilization, which could be used to claim that contraceptive drugs or devices are abortifacients based on the theory that they might interfere with implantation of a fertilized egg. Fetal personhood laws have significant implications for pregnant people, either by limiting the services pregnant people can receive or requiring services pregnant people must receive based on the potential impact on the pregnancy. It could lead to pregnant people being required to receive prenatal care, and if taken to its most extreme, lead to requirements that people capable of becoming pregnant receive preconception care. I'm here today as a partner and an ally to say we must learn from the crisis created by Dobbs. More restrictions will follow, and activists and lawmakers have the tailwind of Dobbs at their backs. NIFR expects to see attacks on the legality and legitimacy of contraception. In his opinion, concurring with the Dobbs decision, Justice Clarence Thomas called into question Griswold v. Connecticut, which is the 1965 decision that made use of contraception legal for married people. Griswold is hugely, hugely important. It marked the beginning of a new era in the Supreme Court for the protection of unwritten rights and set the stage for expansion of that protection over 50 years. Justice Thomas asserted his view that along with the right to have an abortion, the right to contraception, as well as the right to same-sex sexual relations and equal marriage are essentially invented. And he called for the court to revisit its decisions in Griswold, in Lawrence v. Thomas, and in Obergefell v. Hodges. This concurrence is a call to action. And those of us who work in contraception know to expect an onslaught. States may try to pass laws that challenge the right to contraception that are recognized in that line of cases stemming from Griswold v. Connecticut, much as they did in passing laws that clearly conflicted with Roe v. Wade to trigger the litigation that would eventually lead to the Supreme Court overturning the right to abortion. The court's rationale in Dobbs that abortion is not a deeply rooted right in the nation's history and tradition could be applied to contraception by lower courts even before a contraceptive case goes to the Supreme Court, and despite Griswold still being on the books. Overturning Griswold could come in the form of a direct challenge to contraception, such as a state passing a law to test Griswold, or it could come through an indirect challenge, such as a challenge to equal marriage rights. When we anticipate potential challenges, we could consider a full contraceptive ban, a ban on certain methods deemed to be abortifacients, some additional restrictions on certain methods, for example, an age restriction to be able to have an IUD, an age minimum, let's say. We could see bans or restrictions on IVF and other assisted reproductive technology, and we could see the imposition of parental notification or consent for contraceptive services. The attack on adolescent access to contraception is already underway. Earlier this year, a district court judge in Texas issued a final judgment in a challenge to Title X's long-standing prohibition on requiring parental consent for minors seeking contraceptive care. A parent of 3 daughters sued the federal government, alleging that his rights to raise his children were violated by Title X's confidentiality protection, even though he presented no evidence that his children had ever been seen in a Title X setting or that they ever would be seen in a Title X funded setting. He sued over a hypothetical harm, an imaginary harm, really, similar to the concern that George just told us his constituent or a constituent in Iowa raised. But this parent in Texas, in front of Trump appointee Matthew Kacsmaryk, that parent won. This case is on appeal, but for now, despite decades of practice and legal precedent prohibiting parental consent in Title X, people under the age of 18 in Texas can no longer rely on a Title X funded health center for confidential contraceptive care. That same federal judge ruled against FDA approval of mifepristone, one of the drugs used in medication abortion. And this decision is also on appeal. And in fact, just yesterday here in New Orleans, the Fifth Circuit heard argument in that appeal. If allowed to stand, Judge Kacsmaryk's decision has the potential to upend the FDA approval process and put other FDA-approved drugs and devices, including contraception and STI treatments, on thin ice. Contraceptive access is also being impacted outside the courts. Just last month, the Attorney General in Iowa decided to hit pause on the longtime policy of covering emergency contraception and abortion care for victims of sexual assault. And last summer, the University of Idaho's General Counsel issued guidance to employees advising they just stop providing birth control to students entirely. And as this summer opens, we could see Congress take steps to zero out funding for for Title X family planning for fiscal year 2024 appropriations. This combination of uncertainty and legal ambivalence and profound disrespect has deeply impacted professionals working in abortion and contraception. It goes against everything these professionals have trained for and worked for to delay or deny a patient the care they want and need. They are acutely aware that such delays and denials undermine whatever trust a person might have in their provider and in this U.S. healthcare system in general. Clinicians see a future where patient privacy is not respected and are thinking through the unforeseen consequences of basic tasks like dating pregnancies and charting pregnancy loss. The devastating impact of abortion bans and other policies that undermine human and civil rights are deeply affecting clinicians and others in the workforce, and they are not just furiously worried about the people they serve. Clinicians are wrestling with what they can or cannot say or do in states where abortion is banned. They are worried about their licenses. They are concerned they may face civil or criminal charges for doing their jobs, for providing the clinical standard of care. They fear for their safety and the safety of their loved ones. And just the anticipation of these kind of impacts has a chilling effect. As one of our Texas members, a midwife with years and years of experience, told me, the sacred space of the exam room has now become a political exercise. Now, it's not all defense, I'm glad to say. The good news is there's a significant effort in legislatures around the country to pass legislation that would protect or expand access to contraception, and much of this, of course, is in response to the emergency in abortion access. Bills have been filed to protect and define contraception in state law, expand contraceptive access in hospital emergency departments, expand access to emergency contraception, allow advanced practice clinicians to provide contraceptive services, allow pharmacies to dispense contraceptives without a provider prescription, permit access to 12 months supply of contraception, and protect coverage of contraception in insurance plans. Some of these efforts are aimed at increasing access to care, to address concerns about the distance a person might have to travel to find a provider, or just the ease with which they might access their method of choice. But others are addressing matters that are currently protected on the federal level because of the hostility being demonstrated to reproductive rights, health, and justice. State legislatures are working to codify protections in state law should they be tested at the federal level. And in addition to these legislative initiatives, there continue to be efforts to place on the ballot questions about reproductive freedom and autonomy. You know, prior to the November 2022 election, there were no states with explicit protection for abortion, contraception, or reproductive rights in their constitution. But that did change last election day when ballot initiatives to amend the state constitutions to protect abortion access were approved in California, Michigan, and Vermont. And there was a fourth ballot initiative in Kentucky that would have amended the state's constitution to declare that nothing in it protected a right to abortion or required government funding of abortion, but that initiative failed. And now we've got efforts going on in many states, both to seek protections for reproductive freedom and autonomy and to thwart such efforts. So far, these are still more narrowly tailored toward protecting abortion rights, but I do expect to see a broader framing in such efforts going forward. I noted that when I began that I wasn't here, able to participate and engage entirely, but I did look really closely at this week's agenda. And there was so much information and expertise and insight that's designed to support you as you deal with this record-breaking STI outbreak and multiple other crises. I saw that there were sessions on innovation and technology and data and training and capacity building and clinical care and care outside the clinical setting and policy and outreach. Really, really important stuff. So I hope you're all fired up and probably ready for a rest. But as you absorb all that content and begin to plan for how you're going to incorporate what you've learned, I ask you to commit some time to considering how we can strengthen the linkages and collaboration between those of us focused on contraception and sexual health care and those of us focused on STI prevention and treatment and sexual health care. If we were able to step back from our silos, our own crises and concerns, and look across, we would do better together. We would have more effective partnerships at the national level, at the state level, and at the local level. And smart partnerships make it much more likely that we'll have better programming. We will have smarter use of the funds that we have. We would have a more inclusive and nuanced approach to service delivery and more coordinated policy advocacy and education. One of the reasons why I'm so happy to be here is because NIFRA remains what it has been, which is a partner and an ally, and sometimes an early warning system for those of you who are focused in HIV and STI prevention and treatment. In this room, we're representing so many experiences, perspectives, levels of worry, and of hope, and we can build from what we have in common, which is our commitment to caring for those in our communities who need help, who may be marginalized or vulnerable, who the system may overlook or undervalue. So while the STI community may not be experiencing the legal setbacks or funding restrictions that my field is enduring, we have that common cause. The people we seek to serve are under threat, and it's a threat that affects people no matter their age, their gender, sexual orientation, gender identity or expression, and it affects them no matter where they seek health care. In some cases, that will be through an STI clinic. In others, a primary care setting, and in others, a healthcare center that focuses on family planning. People who trust us are suffering from the impact of legal rulings and policy decisions, and they need us to do all we can to ensure they can get the health care that they need. So, as a final takeaway, I urge you to learn from us, and as George said, get ready. And more than that, I ask, where you have power and capital, that you use some of it now to ally with us. As we battle through these extreme policy changes, we know the opposition isn't making claims based on fact or science or public health guidance. Some of the court system and legislatures are set against fact and science. So much of this has become very ideological or outright partisan. The fight in front of us will not be fair play. It will be a longer effort to reframe and reclaim our rights, and the length of time it will take will be more than any of us can bear. Because as we make our way through this, there are consequences. People are being harmed every day, and when it comes to care, so consequential as sexual and reproductive health care, those harms may not be able to be undone. Despite this, I want to say that I am sure that we will secure our human rights again, and on a more expansive and inclusive basis than ever before. I believe there will be a new cohort of leaders that emerges, not necessarily a new generation, because I don't think this is about age. I think our new leaders will be those who step forward with determination and clarity of purpose, people who are smart with their risk-taking and are not afraid to take on a system that is broken for so many. And I'm conscious as I say this that there are hundreds of you here at your first NCSD Engage meeting, and you may just be joining the field. And I'm also conscious that there are many people here like me who have spent their years of professional service devoted to advancing and protecting access to sexual health care. Any one of us could be part of that new cohort of leadership, and I urge every single one of you to consider answering that call. Because I can tell you, there is no more worthy work. People's expression of their sexuality, their rights to be free in themselves and in their intimate lives, these are foundational to who we are as human beings. So for our own sake, and for the sake of millions of people whose care and education we have a part in supporting, I hope you leave this meeting with the information and inspiration you require to say what needs to be said and do what needs to be done. Because if you take up your part in this fight, we will win. Thank you.
STD Engage to close Engage 2023, coming back stronger. Please welcome David C. Harvey.
There's a very special person at the back of this room, and her name is Jennifer Zeal. And Jennifer Zeal brings all the zeal you could imagine to providing discipline to all of us unruly speakers who do not like to be scripted. Jennifer, I'm going off script. I'm not going to be reading this speech through these little fancy presidential teleprompters because I want to take a moment to speak to you a little bit more from the heart. I don't know how you're all feeling, but I feel overwhelmed. Overwhelmed for these incredible presentations we just heard. Another huge round of applause for Stephanie, George, Claire, Greg, and all of our incredible presenters this week. I don't think I have to speak for all of you when I say that hearing your stories this week, particularly from you who are the heart and soul of the public health system in this country, DIS, to see some of you move to tears with hearing about your work from colleagues across this country, to hearing about the threats to the DIS funding in this country, to hearing your personal experiences of working on COVID, being redeployed to COVID, and watching people pass away, has moved the NCSD staff and me to tears. You are heroes. You're the backbone of this system. And from all of us, I thank you from the bottom of my heart. This is a watershed moment for our sector. 1,200 people strong at this meeting. At the beginning of this meeting, I asked for a little bit of grace and patience for what you would encounter this week because we turned no one away, as you all know. And my gosh, did we get that back tenfold. You were patient. You wore jackets when it got cold, took them off when it got hot, put chairs in the hallways to listen in on sessions that were packed to the gills. For that, I really want to thank you. Thank you from the bottom of my heart. NCSD is an organization that has gone through tremendous growth and change due to all of you in this room and your participation in our national work. Where are we going from here? I'll give you a couple of hints. Our board of directors, our wonderful board of directors, passed a new strategic plan for us on Monday. And you've already, it's a lot of words, it's a technical document, but here's really the basic scoop. We're moving away from the use of STDs to STIs. We're embracing a sexual health agenda. We are setting a path toward continued future growth. And we're going to examine the name of the organization, because we are establishing seats on our board of directors for DIS and STI clinics. That's a big deal. After we leave here this conference, there are more sessions, post-conference sessions after this one. We're going to continue the work and the conversations through STD Engage special edition sessions. So look for information on that. If you have not signed up and are a part of the MyNCSD community, do so. It's free. It's a way to exchange ideas and information from folks from across the country. Thank you for traveling to New Orleans and attending this conference. A huge shout out and thanks again to the most wonderful team of people I work with, the NCSD team. Where are you? Please stand. Kathleen Genty, where are you? All things STD engaged flow through Kathleen Genty. A huge shout out and thanks of appreciation to Kathleen Genty. The NCSD board, who I've already mentioned, the hardest working group of folk who help this organization day in and day out. Our sponsors for this meeting. Like all of you in this room, we started out an exercise where I asked you to introduce yourself to other people. I have my own personal network of support and care. I could not do this work. I could not have survived all these years doing this work without that network. I'm getting old, folks. I am going to be 62 years old this year. I know I don't look it, do I? That was a little leading of a question. But the list of people to thank is too long, but I have some wonderful personal friends who have been with me throughout the years here in this room. Dorothy Mann, Betty Lou Taylor, I don't know if you're in the room, but a huge shout out to you. Two very old friends and colleagues are here, the former executive directors of NASTAD, Julie Schofield and Murray Penner. Where are you? Murray, of course, is now the director of the U=U Plus organization. TJ Rivetti from Orashore, you drive me crazy, but I love you. And my partner and husband, Leo Morales, who's watching live stream from Fort Lauderdale, Florida. Leo, I love you. Thank you for your daily support. All of you who can, I want you to stand right now. We're going out with a bang. I want you to repeat after me. Are you ready? Are you ready? We are the team.
We are the team.
With the biggest heart. Toughest practices. Best game plan. Strongest togetherness. Will to succeed. This day is ours. Let's take and capture success. See you at let me get the name right. Jennifer Zeal, I got the Q wrong. See you at STD Engage 2024 in Washington, D.C., where we are going to storm the halls of Congress.